Okay, yeah. Hi, everyone. My name is Marilyn Moy. I am the founding medical director of our pulmonary rehabilitation program here at VA Boston. I'm also an associate professor of medicine at Harvard Medical School, and I am the current chair of the Pulmonary Rehabilitation Assembly for the American Thoracic Society. So my interests are very much in promoting pulmonary rehabilitation, educating our patients as well as providers on what exactly pulmonary rehabilitation is, as well as trying to improve its access and implementation and utilization out on the front lines. So I'm really happy to be here to talk about an update on virtual pulm rehab. I was connected to this group through Grace Ann Dorney Koppel, who has been an amazing pulmonary rehab advocate for us, for all of us. And unfortunately, she isn't able to join us today, but I wanted to thank her for this opportunity. So I should be sharing my slides already. So I'm going to make sure that they are advancing here. So just start with my disclosures. So these include my grant funding through VA as well as the NIH. And I also serve on a data and safety monitoring board that's related to physical activity promotion and pulmonary rehab. So my goals today are fourfold. So first I will discuss the rationale for remotely delivered or virtual pulmonary rehabilitation. Then I want to discuss the results of a survey that we conducted with ATS looking at U.S. remotely delivered pulmonary rehab programs here in the United States to get a better understanding of the landscape currently. Then I will present a synchronous two-way audiovisual teleconference pulmonary rehabilitation program. This is a program that we developed here at VA Boston as an example and a model of what a program could look like for a virtual platform. And then finally, I would love to engage in discussion with you, the audience, to better understand the pros and cons of this modality, where you are. My talk should be about 40 minutes, so there is time programmed in here for us to have a conversation. So I'll start with this 2023 ATS Clinical Practice Guidelines on Pulmonary Rehabilitation. This document highlights that pulmonary rehabilitation is standard of care in the treatment of chronic lung disease. We certainly have the most evidence for patients with COPD, so that's where I'll focus my talk. In patients with COPD, we know that pulmonary rehabilitation significantly improves symptoms of dyspnea, exercise capacity, and health-related quality of life, with gains that are similar to those seen in trials for pharmacologic agents. It's also been seen in an analysis of US Medicare data that after an admission for a COPD hospitalization exacerbation, that those who participated in pulm rehab had a lower risk for dying compared to those who did not. So lots of evidence to support center-based pulmonary rehabilitation. It rests on 4 decades of evidence. And currently, any individual with chronic lung disease who experiences breathlessness that affects their functional status and health-related quality of life is eligible to be evaluated for pulmonary rehabilitation. This is a page from the 2025 GOLD guidelines for the non-pharmacological management of COPD. I show it to highlight the distinction between pulm rehab and physical activity promotion. Pulmonary rehabilitation is an essential recommendation for patients with stage B and E COPD, whereas physical activity promotion is recommended for all our patients with COPD. If you look at the GINA guidelines for asthma care, it also clearly distinguishes between these two entities in terms of physical activity promotion and pulmonary rehabilitation. So what exactly is pulmonary rehabilitation? So for many of you, this is singing to the choir, but just to recap, so pulmonary rehabilitation is a multi-component, multidisciplinary intervention comprised of supervised group exercise training and education on disease self-management. Our patients typically present to us with symptoms of breathlessness. They also have a significant degree of deconditioning. So certainly pulmonary rehabilitation does not proclaim to reverse the fixed defects that we see in COPD, for example, but certainly we can reverse the degrees of deconditioning that our patients present with. We all are familiar with this cycle of inactivity. So the less that we do, the weaker our muscles become. Those weak muscles use more oxygen and are less efficient in extracting that oxygen. And through very complex central and peripheral mechanisms, we feel breathless. Understandably, we become fearful of activity that makes us breathless. and we tend to avoid those activities. And around we go in this cycle until we become quite sedentary. And again, this is where we find many of our patients who are referred to pulm rehab. And pulm rehab aims to break this cycle of inactivity with exercise and education. It also targets biopsychosocial factors such as fear avoidance, kinesiophobia, anxiety, and depression. It aims to bolster exercise self-efficacy and confidence. These are pictures from our program here at VA Boston. Again, the exercise component is the cornerstone of pulmonary rehabilitation. It targets the dyspnea level in terms of using the Borg rating. It targets the heart rate if patients are not on beta blockers, to use that to help us. And it is anchored squarely on an exercise prescription that's based on a functional test, as well as a clear plan for exercise progression. Most programs run 2 to 3 times a week for 9 to 12 weeks on average. And so we only have these patients for a short time, but our goal during that short time is to make sure that we are progressing them and that we're trying to reach their target levels. There is definitely a component of strength and resistive training. You see here patients are either using resistive bands or free weights. We always meet our patients where they are. We are targeting both the upper and lower extremities. And these are really unique opportunities to monitor our patients, number one, in terms of symptoms, oxygen saturation, and their vital signs, but also as an opportunity to educate our patients when they're exercising and symptomatic. Most of the time when we see our patients in our offices, they're sedentary, they can't reproduce their symptoms. And so these are really teachable moments. So time to, at the machines, to be able to teach our patients about their breathing techniques, their pacing, and then awareness to chronic pain sites, for example. So these are, again, very unique clinical times with our patients. The education component is also another important part of pulmonary rehabilitation. These are common topics that are delivered, but they range from medical management in terms of early identification of COPD exacerbations, to really understanding their anatomy and physiology, to using oxygen therapy when exercising. And then again, because it is a short course, we always from day one are thinking ahead and trying to figure out how these patients are going to maintain their positive behavior change over the long term after they leave us. So we rest heavily here in our program on our behavioral psychologists who deliver a big portion of our education, looking at ways to maintain their goals, setting goals and coping with lung disease so that they can maintain an active lifestyle. We also partner with our pharmacists as well as our nutritionist in order to deliver our multidisciplinary education. So despite the proven benefits of pulmonary rehab, it continues to face many challenges with regards to access and adherence. We know that healthcare providers refer less than 13% of the potential candidates who would benefit, so it is quite underutilized. We know that programs are typically based at medical centers or outpatient medical offices. We ask our patients to travel to us 2 to 3 times a week. So there is lack of access and there are significant barriers. And then both in the US as well as globally, we know that pulm rehab non-completion rates can be as high as 20 to 40%. So there's a high dropout rate worldwide. A lot of this is because our patients are so sick to start off with, and they have their exacerbations, and this pause and restart of exercise is quite challenging for them. And so, how are we doing in terms of providing access to pulm rehab? This is a map that was lent to me by Dr. Tony Puntieri from the NHLBI. The blue dots represent certified pulmonary rehab centers. This was a few years back, of course, but it does send home the message that, number one, we are in dire need of more pulm rehab sites, but also two, that these sites that are in existence are not distributed equitably or equally across the United States. They are clustered here in the Northeast and then in the upper Midwest, and then with some smattering in the South. And then certainly fewer in the Midwest and then towards the West Coast. And on average, we are estimating that there's currently only one pulm rehab center per every 43,000 patients with COPD in the US. We know from a paper that was published back in 2012 that only 3.7% of US Medicare beneficiaries utilize pulmonary rehab. Sadly, 10 years later, in another paper published in 2023, those rates have not really changed. And that paper, led by Dr. Sari Abbat and his group, showed that, again, among Medicare beneficiaries, 2/5 of older adults with COPD had poor access to pulmonary rehab, with markedly worse access for those patients in rural areas. And then how are we doing in the VA? So there's perception that because we are a large integrated healthcare system that we must be doing better in uniformly bringing guideline-based care to our veterans. But I wanted to share this slide with you. This was presented at the ATS conference back in May and just recently published in the Blue Journal as a viewpoint. And we show that there is actually an alarming loss of center-based pulmonary rehab programs in the US within the VA. So we looked at the Corporate Data Warehouse, which is a national database of all veterans who seek care in the US at a VA site. And we used Medicare CPT codes. We were very conservative in the codes that we used, that this is all either center-based or using the modifier codes for synchronously delivered pulmonary rehab. And we were able to identify the centers that delivered pulmonary rehab to patients with COPD. So on the left here, you see this map of VA pulmonary rehab sites in 2018. So this was pre-COVID-19 pandemic. There were 125 sites, so not a large number, but still, it seemed like they were distributed well across the U.S. And then here in 2022, post-COVID-19 pandemic, the center base are represented in the blue dots. The remotely delivered are in the yellow stars, and then centers that delivered both modalities are in the green triangle. And you can see here that we have dropped down to a total of about 35 programs delivering, again, guideline-driven care to our veterans. There's been a dropout here in the Midwest that we couldn't explain with the data that we have, but this is a cause for alarm and also a signal that we really should be looking at all sites, non-VA sites too, to really understand what is happening in regards to delivery of pulmonary rehab in the United States. So certainly there is a need based upon these data and in terms of access. There is a need to leverage technology to fill in these gaps and to try to deliver pulmonary rehab virtually. I believe that we are all in agreement that virtual pulmonary rehab is not a replacement for center-based sites, but certainly we want to use technology to increase our access to our patients. And more recently, there has been an emergence of standalone commercial entities that are not connected to community-based or academic-based hospitals. So 2 years ago, at the end of 2023, we did partner with the ATS to conduct a survey nationally to better understand and characterize U.S. virtual pulmonary rehabilitation programs. So these results, again, were recently published, so back in the spring of this year. This is a paper in the Annals of ATS. It's entitled Characteristics of Virtual Pulmonary Rehab Programs in the United States, Results from a National Electronic Survey. Excuse me. So we identify programs from the Live Better database, the internet, as well as from scientific publications. In the VA, we identified sites by using an email that was sent out to all medical service medical chiefs asking if their site offered remotely delivered pulmonary rehab and whether they would be willing to respond to a survey. And then internally, this group here, as well as folks at the ATS, we worked together to develop a 40-question online survey. And this survey aimed to assess delivery methods, program content, as well as outcome assessments that were being conducted by the programs. Ultimately, we emailed the survey to 53 programs in December of 2023, and we were able to recover the final results in early January of 2024. So my next few slides are going to share with you the results of this survey. So here we have some general characteristics. So of those 53 programs, 41 programs completed the online survey for a pretty high response rate of 77%. The 12 programs that didn't respond, two of them were offered by non-VA outpatient hospital departments, and 10 were VA outpatient departments. There were 30 programs that either currently or previously delivered remote pulm rehab. 23 were offered by an outpatient hospital department, so 7 were non-VA, 16 were VA, 5 were commercial entities, 1 was located at a physician office, and then 1 was independent. And then notably, there were 5 programs that responded, but currently we're not delivering remotely delivered pulm rehab, but had previously delivered it. And notably, 4 of those 5 were non-VA outpatient hospital departments, and 1 was by the VA. And this is important because we know that Medicare stopped reimbursing hospital-based virtual pulm rehab programs when the public health emergency ended. And so that effectively shut down virtual pulm rehab models that were being delivered by hospital-based academic centers. So that's echoed here by these numbers. And you can see the reasons for stopping were not paid for by insurance, limited or insufficient staff, not popular with patients, and the need for more virtual resources like monitors and iPads. We found that all but 3 programs also offered conventional center-based pulm rehab, which is important to have that expertise. Of the commercial programs, only 1 of the 4 also provided conventional center-based pulm rehab. Program experience ranged from 6 months to 5 years. The average number of sessions offered was 2 times per week over 12 weeks. The average duration of each session ranged from 20 to 90 minutes, with 60 minutes being the most common response. And then the number of sessions considered as program completion varied between 8 and 36. All of the programs said that they received referrals from healthcare providers, which is not surprising. However, in terms of patient self-referrals, we found a discrepancy between the outpatient hospital departments and commercial sites. So only 5% of the hospital-based outpatient departments endorsed receiving patient self-referrals, whereas 60%, so 3 of the 5 commercial sites took their referrals directly from patients, so without any intervening provider. All commercial programs did require MD physician clearance, while 21% of the responding sites offered by outpatient hospital departments did not require physician clearance. And then in terms of the patient population, not surprisingly, COPD, interstitial lung disease, and post-COVID-19 were the most common diagnoses. The reasons for excluding patients from their program are centered on comorbidities and disease severity. 3 programs explicitly said they had no exclusions, that they based it on a case-by-case basis. 3 programs specifically said that they deferred to their medical director or to their physician on a case-by-case basis. And then importantly, because we really want to document the reach of these programs, certainly the promise is that if we're going to deliver this intervention virtually, that we are going to be able to access and penetrate more communities. But there have been very few studies that have rigorously looked at this, and so we looked at the zip codes of these entities, of the programs at least, and we found that none of them were actually small town or rural, that all of the programs were based in metropolitan, urban, or micropolitan sites that are represented here in the beige states. The different dots represent how many virtual sites are in that state. So again, some evidence that maybe because we're just starting to see these programs implement their programs and are starting from urban sites, but there's still very little documentation that we are reaching the rural patients. So then in terms of method of delivery, we found that all but 3, so 88% of the respondents delivered their programs synchronously, so 2-way face-to-face video. Because sites could actually choose more than one platform, we also found that almost half of the VA sites use the telephone as well, asynchronously. And then interestingly, 3 of the 5 responding commercial sites, so this is 60%, used pre-recorded video and website and mobile applications. So these are, again, delivery modes that still require some evidence base in order to substantiate their evidence, but it was interesting to see this differences between different responding sites. So this is a figure from the Defining Modern Pulmonary Rehabilitation ATS workshop that was published in 2021. Some of you, or hopefully all of you, are familiar with this documentation, but it was led by Dr. Ann Holland. It was an international study where they used the Delphi technique, where they surveyed providers who delivered pulmonary rehabilitation and asked them what are the essential components of pulm rehab, regardless of whether it's delivered by center-based modality or by virtual modalities. And they published these 13 essential components of pulmonary rehabilitation. So in terms of the survey responses that we found, the next slides will show how they measure up against these metrics. So the first part was focusing on outcomes assessments. And you can see here that the workshop report advocates for an initial center-based assessment by a healthcare professional, at which time that an exercise test is performed. This is important because that is what the prescription is based on, and the CLARE plan for exercise progression is also based on. They also advocate for assessing quality of life, as well as assessing for dyspnea and other symptoms. And so how do the respondents for the virtual pulm rehab survey do in terms of measuring up to these essential components? So all of them did assess for symptoms. 96% assessed exercise capacity or some form of functional exercise. 88% assessed health-related quality of life. You can see here that 79% assessed for physical activity, which isn't one of the essential components of pulmonary rehab. And then surprisingly, only 62% said that they assessed for safety. And then having let's look at this more granular breakdown. You can see that 29% did their assessments only virtually, so they did not bring these patients in person. And this includes 100% of the commercial entities. So the recommendation for an in-person assessment was not done by these commercial entities. Whereas here you can see that over three-fourths of the hospital-based, either VA or non-VA programs did use the 6-minute walk test, which is conducted in person, whereas the commercial entities used the shuttle walk test and the sit to stand. So it's important to acknowledge that currently there is no test that can be performed remotely on which it has been shown that an exercise prescription can be validly implemented. I know there's work being done by Narelle Cox and her group in Melbourne, but at this time, it is important to bring our patients in person to use either the 6-minute walk test or a cardiopulmonary exercise test to figure out both for safety reasons and where they are in terms of their exercise prescription. Next, so what about the components of the exercise training? So here we know that endurance training, the aerobic training is important, as well as the resistive training. These are the hallmarks of pulmonary rehabilitation. So in terms of our virtual pulm rehab survey, how did everybody do? So all but one of them said they did provide aerobic endurance training. All but 2 said they provided resistive training. All programs provided dyspnea control techniques and education sessions. And then you can see here that about 3/4 of the program said that they delivered exercise equipment to the home. So these included pedalers or resistive bands. Interestingly, the VA had over half of the programs say that they also used a pedometer in terms of their exercise training. So I'm not sure if they are one of these people who sites that did not provide endurance training, but it's important to note that community-based walking, which is physical activity promotion, which is important, is not pulmonary rehabilitation, and it's not aerobic exercise training. So that was an interesting finding. And so then moving on to other outcomes. So here, again, in the Defining Modern Pulmonary Rehab workshop, we know that an exercise program needs to be individually prescribed, needs to be individually progressed, and that it requires a team of healthcare professionals with expertise and experience in pulmonary rehabilitation. With regards to our survey responses, we found that 92% of them, so all but two, reported that they did provide an exercise prescription, which was reassuring. But it was very heterogeneous in terms of how programs progressed their exercise training. Some used vital signs, others used patient-reported symptoms, and then some programs did endorse using pedometer step counts. And then nearly a quarter of the respondents did not answer this question about how they progressed exercise training. So it is very unclear how many exercise US programs use supervised or even unsupervised walking as the focus of their aerobic exercise training. And as we saw on the GOLD guidelines, the physical activity promotion is distinct from pulmonary rehabilitation. So in summary, on this part of my talk, the U.S. remotely delivered pulmonary rehab programs are quite heterogeneous. The total numbers are low. None are in rural areas. There's a notable lack of in-person evaluations, a lack of in-person standardized exercise testing, and plans for exercise progression, particularly by commercial programs. It is alarming that nearly half of the respondents did not assess for safety. We found trends that VA programs tended to use the telephone as a delivery method and provided pedometers. There's a trend that commercial entities tended to use pre-recorded materials, websites, and mobile applications. As always, our goal is for our patients to be as active as possible. So certainly if our patients can't get to a center-based pulmonary rehab program, then a virtual program may be a good choice. The ultimate choice of the pulmonary rehab delivery model depends on the patient preference, the program availability, and shared decision making. But as providers referring our patients, it is very important for us to know what the programs are provisioning, because if our patients are going to spend the time doing it, we want to make sure that they receive the expected outcomes, which have been documented in our center-based pulmonary rehabilitation programs. And then we did find some evidence to document that hospital-based outpatient remotely delivered programs have closed due to lack of reimbursement by Medicare. So in this next part of my talk, this is the third bullet in terms of my overall goals. I want to share with you our model here at VA Boston of our virtual pulmonary rehab program. We delivered this program in the fall of, we developed it in the fall of 2020 when in response to the COVID-19 pandemic. So currently we do offer our patients either our center-based pulmonary rehab program or this virtual model. But for both programs, we do conduct an initial and exit evaluation in person in order, again, to develop that exercise prescription and plan for progression. I'll show you a video of our program in the next slide. I think the video is worth 1,000 words. But you'll see that this virtual program is very well integrated into our overall program. So both programs run Tuesdays and Thursday mornings for 9 weeks. The synchronous exercise classes are delivered here on the monitor using our VA Video Connect, which is VVC. And so they are given an iPad if needed. We also send them a pulse oximeter if it's as needed for oxygen saturation or heart rate monitoring. We don't send them any exercise equipment, but the physical therapist and I have developed a circuit of exercise that try to mimic the duration as well as the intensity of center-based pulmonary rehab so that we're able to get patients' heart rate and board ratings up to their targets. We also focus on strength training. And then we do send home a Fitbit pedometer for these patients. And on the days that they're not in class, we do advise them to increase their walking as a way to promote physical activity at home. So when these patients finish their exercise and have cooled down, they stay on the screen. While they're doing that, the patients who are participating in person are gathering in the gym. And then we provide our education for both groups at the same time. When education is done, these folks on the screen sign off, and then the people in the gym start their warm up and then move over to the equipment. So in this next slide, I'm going to try to share my video. And so you just bear with me here. I'm going to stop sharing because I need to reshare in order to turn on the audio. So I'm going to stop sharing here.
Not bad, not bad.
It starts before the class, making sure that we've done a full assessment to make sure that they are safe to participate. And we've already identified patients that are safe to participate and are going to...
So you cannot hear the video?
We can hear it, we just couldn't see it. So I don't think you shared the screen.
Okay, let me try that again. Sorry about that. Oops, now I lost the video. Yes, please give me the feedback if you can hear or see it and see it. Let me try that again.
Overall.
Not bad, not bad.
It starts before the class, making sure that we've done a...
We can hear it, but I don't think it's... I think you need to share your screen to this, like the screen that has the video up.
Yeah, okay, let me try this again. I think it is worth this, so just bear with me here. So, let's see, share. Let me show my share screen too, maybe.
Participate and are going to benefit. The program is great because it allows them to issues with traffic. The benefit comes from consistent participation.
It's still showing us your PowerPoint. It's not showing the screen that has the video on it.
Okay.
Time.
There you go.
So it's designed to be both approachable and flexible for various levels of fitness. It's one of the real benefits of participating in a program like this is that you see your practitioner and I see my patients far more frequently than I would if I was just doing an annual or semi-annual appointment with my primary care or with my pulmonology department. The program is 18 visits plus an assessment period plus a discharge, so 20 visits total. I get a real feel for what their life is like. We do a brief warm-up, and then we go through aerobic circuits and a strength module. So we have 4 modules, 3 circuits, one standing, one seated, and a second one standing. We have designed it that way specifically so that the virtual people get the exact same amount of exercise as the people in our clinic for our face-to-face group. Not everybody has a treadmill or a bike at home, but we've structured it so that they are able to get a commensurate level of activity. And we've set it up so that the muscle groups used are vary throughout the course of the program, so we can avoid things like overuse or repetitive use injury. And we have a seated module with and cues throughout for pacing, so that even patients that don't feel like they're ready to do as much exercise as we describe, there's options for everyone. You can stop and rest and break as much as you need to, and then the seated block gives a chance for people to exercise that have trouble with standing on their feet for the whole 15 minutes. And then we go into a strength module, which is designed to work on upper body endurance, on posture, so that they are in a better position for improved posture for breathing and are able to carry out day-to-day activities in a way where they don't experience breathlessness or dyspnea as severely as they have in the past. And then we do a brief cool down just to sort of get back to their baseline level, make sure everybody is safe and comfortable, and they leave us feeling good about their participation.
Further.
There's a little bit of a learning curve, right, when we're kind of, especially if we're grazing throughout the day, and again, keeping in mind kind of what our weight goals are, right? So the difference between maybe constantly eating, constantly snacking on things, versus, again, are we having kind of a good mix of different foods? Maybe not each snack, right, will look like this. Maybe we won't have all 4 of our food groups, but I always kind of like to say maybe, 2 different food groups for a good snack.
So patients.
All right, so that was the slide. So let me just get us back to my presentation. Okay, great. So that hopefully that was helpful. And can you still hear me?
Yes, you are good.
Thank you. All right. So then we were able to examine our clinical experience and publish the result of our program. So this is a paper that was just published in Chest Pulmonary in June of 2025. And it's entitled A Two-Way Audiovisual Teleconference Pulmonary Rehabilitation Program is Safe, Feasible, and Expands Geographic Catchment. So we looked at our patients enrolled between 2020 and 2023. We had 107 patients who we could examine, and 62 of them were via the virtual modality, and 45 came to us in person. Again, the decision as to which mode they used was shared between the patients and we, the providers. We did not have any a priori set guidelines as to how much oxygen was meant one modality versus the other, or how far they lived in terms of which modality they could use. Most patients had the COPD as their primary or secondary diagnosis. We also had patients who had interstitial lung disease, patients who were pre-lung transplant, as well as post-COVID-19. So we found that the number of completed sessions were no different between the 2 groups, which we were a little surprised by. We thought the patients who were exercising in the convenience of their homes would be, more compliant, or that the patients who had to travel to us would be less compliant. But we did not find a difference between the 2 groups. And we also did not find a difference between the 2 groups in terms of the amount of oxygen that the patients required on average. And so again, beforehand, we would have hypothesized that the patients who were on more oxygen were our sicker patients and would be exercising face-to-face with us in order to have the direct supervision in case for safety reasons. But it turned out that we had patients exercising at home on 6 liters who had ILD, for example, and we didn't run into any problems. So this is our safety slide here. It's a little busy, but what we can focus on here is that this row is the face-to-face group, and the row right below it is the virtual group, and then all the way to the right here, these 2 columns are the event rates adjusted for the number of person days observed. And you can see that the total number of adverse events were no different. So 7.6 in the face-to-face versus 4.2 in the virtual group. And then adverse events that we thought were pulmonary rehab related were also no different between the 2 groups. So 1.5 versus 1. And you can see these, we did try to characterize these adverse event types. So a lot of them were pulmonary. So based upon their underlying pulmonary disease, this was not a surprise. And then we had some cardiac and musculoskeletal events. We tried to, in a standardized way, assess for feasibility and acceptability. So we did administer a questionnaire at the exit evaluation. And you can see there here that all patients in either modality said that they were satisfied with the program and that they would recommend the program to others. For the virtual group, 100% of them said that the exercise classes were easy to understand, and most importantly, that they felt safe exercising in their home during the virtual video sessions. And then over 90% of the patients said that it was easy to connect to the program, the connection was clear, and that the education sessions were easy to understand. In terms of geographic catchment, again, very little data out there, so we thought this was important to document. We really wanted to see if we were enrolling patients in our virtual program who we normally would not be able to capture with our center-based program. So this was not rocket science. We used Google Maps and we looked at the travel time as well as the travel distance in terms of where these patients lived compared to where our center is located, represented here in the blue dots. And you can see here that in the in-person group on the left, this is where the patients lived, and compared to them, those who participated virtually lived twice as far from us. So this was both in terms of drive time, so this was 85 minutes versus 53 minutes on average, as well as distance. These patients lived about twice as far from our center. So we were in fact capturing patients who normally would not be traveling to us to receive pulmonary rehabilitation. This is our exploratory functional outcome slide. Again, we definitely were not powered to look at these differences, nor was this a randomized controlled trial. But we were curious, of course, to see if there was any signal. But we showed that there was no difference between the two groups with respect to change in 6-minute walk tests. So using the MCID of perhaps 30 meters, the VVC group was at 40 and the face-to-face group was at about 24. And we didn't see any difference between the two groups with respect to other functional testing or in terms of the change in dyspnea score. So again, some interesting signals here, but it's certainly not definitive. So in summary here, a synchronous remote pulmonary rehab delivery program is feasible. It can be readily built out from center-based programs, and this is my vision that we can, at center-based programs, be a hub. This is where expertise lives. These are where our multidisciplinary professionals, healthcare providers are located, and that we can build out these spokes, particularly here in the VA. When the Mission Act was passed, it allows us to deliver care across state lines. And so the spokes can be endless. And so I thought this is good evidence that it is possible. It appears that we can ensure safety and patient engagement with our virtual program. We did expand geographic catchment, and then our preliminary data do show similar outcomes to center-based pulmonary rehab. So, toward the best of my knowledge, there's only one other program in the United States that was published, and this is, again, Saria Butt's program down at UAB in Birmingham, looking at a synchronous video teleconference program. And the reason that we're harping on this modality is because currently this is the only way that Medicare will reimburse for remotely delivered pulmonary rehab now, is that if it's delivered synchronously. And certainly for safety reasons, it does make sense that in order to optimally progress our exercise and for patient adherence and motivation, that the pulmonary rehab healthcare professional is observing the patient's exercise in real time, and that the patients can see us in real time exercising with them. So these are my last few slides, and then I will open this up for discussion. I wanted to talk a little bit about terminology. So right now, I think the word salad out there is dominated by the word telerehabilitation. This is certainly used in the Cochrane Review in 2021, led by Dr. Norel Cox, which I think really propelled this field of virtual pulmonary rehab into where it is today, particularly here in the US. Also want to highlight that it does state, however, the certainty of the evidence provided in this review is limited by the small number of studies, the varying models, and the relatively few participants. And then also tele-rehab is again used in the 2023 clinical practice guidelines by the ATS, on which I was a member. We did use the word tele-rehab. The recommendation was that we should offer the choice of center-based home rehab or tele-rehab. This was a strong recommendation based on moderate quality evidence. But we did also put in the caveat that tele-rehab should be considered as an alternate to home rehab and not as a replacement for center-based home rehab. And so in this viewpoint that was just published in the Annals of ATS literally yesterday, last Friday, we did, my colleagues and I did put this viewpoint out looking at why it matters to clarify our terminology. And this is the structure that we favor. So we believe that tele-rehab is a very general term that defines delivery of rehab, any rehab from a distance. So this could be cardiac rehab, rehab for our spinal cord injury patients, or pulmonary rehab. But that pulmonary rehab with all of the essential components can be delivered either through center-based or telepulmonary rehab. And this is delivery remotely in the home, the community, or at a clinical site that doesn't have pulmonary rehab of its own. And then telepulm rehab can be further subdivided into synchronous telepulm rehab or virtual pulm rehab, which would be, again, two-way audiovisual teleconference to the model that is currently reimbursed in physician offices by Medicare, or by asynchronous modality. So this is remotely delivered pulm rehab via telephone calls, pre-recorded videos, websites, or applications. Again, emphasizing that these types of models, the asynchronous models, do run the risk of ineffective training and do bear the burden of demonstrating that they achieve the same outcomes that are essential to effective pulmonary rehabilitation. Out here in this orange box are technology-enhanced physical activity interventions. So these promote physical activity using wearable technology, website pedometers, accelerometers. They use websites and or applications. They may be part of self-management or health coaching programs, but these do not provide pulmonary rehabilitation. So in terms of current questions that still surround telepulmonary rehab, we're still left with how closely can telepulm rehab maintain fidelity to conventional pulm rehab? How can telepulm rehab programs be standardized? We need quality standards. We need safety parameters. We need clinical criteria to identify our patients. We need data to determine its reach. We still need to understand its impact on center-based pulm rehab utilizations. In the US, we are still in need of reimbursement models. And then we know that it would be problematic for patients or insurance companies to pay for commercial or any virtual pulm rehab programs that do not have demonstrated efficacy in outcomes expected from center-based pulm rehab programs. And then we are also very concerned in terms of whether there is still that we can maintain equitable delivery and uptake of virtual services. We know that there's a lack of internet services that disproportionately affect rural communities, and that there is low uptake of technology that's prevalent among our older adults who make up most of our COPD population, for example. So with that, I'm going to end by thanking my clinical pulm rehab staff here at VA Boston, as well as the ATS staff who helped us with the virtual survey. And then thank you for being here today on this nice summer day. Really thank you for your attention, and I'm really eager to hear your responses and how you're viewing and how you're delivering virtual pulm rehab where you are, and how this, how you are managing center-based and virtual pulm rehab in West Virginia. So thank you very much. So I'm going to stop sharing my screen now.